difficulty, but let's see if we can pick up where we left off. So, Dr. Shaw, if you're with us, perspective on sort of, has the pandemic resulted in a new perspective needed in healthcare?
Yeah, I just want to make sure you guys hear me okay.
We can hear you.
Yep. Perfect. Yep. So what I was saying is, I'll speak in two perspectives, from a pediatric perspective and the adult perspective.
And we've got a little bit of a connection point. So as we resolve that, let's move over to you, Bradley. Bradley, say a little bit about CLASS for those audience who don't know CLASS. I'm not sure that that's the case, but it's always nice to check. And then, you know, you've had a broad perspective. What have you seen in this regard?
Yeah, so a little bit about CLASS. Kind of the easiest way to think about us is we're like Consumer Reports, but healthcare IT. And so we cover everything in software and services for providers. And our end goal is to provide transparency to the marketplace about what experiences is really like. You know, and so any provider or payer organization, or those who provide healthcare, can get access to what CLASS publishes. And the only ask that we have is that you share your perspective with us about the things that you're doing and working with. So, so with that, we have really seen some interesting things when it comes to how this has changed over the last, last 2 years with the pandemic. One of the most interesting things was it's really a shift towards consumerism. And one of the most shining examples of that was the increase in telehealth. And so we, internally, we've done some research, and we had about 10% of organizations that had some form of telehealth strategy. And they're like, yeah, it's about 10% of our visits are telehealth based. And then the pandemic happened and it jumped up to about 60% of all visits were based, telehealth based. And now we're expecting that over the next, 6 months to settle probably between 30 and 40%. So overall, it's been an upward shift into, okay, what's more convenient for me? Now, my wife and I went through this several months ago when, pre-pandemic, we learned how convenient telehealth was, because she wanted to go into the doctor, but she's like, I can't leave the baby at home and the other kids. Like, I just can't do it. I'm like, oh, well, just dial up telehealth. Like, you could do that. And she did. And she goes, I am never going back into the hospital again if I don't have to. That was so convenient. So we're really seeing that those things that drive convenience for consumers, those have really picked up, and we'll see a lot more of that post-pandemic.
Those are great comments, Bradley. And you went through this at CLASS, and in my experience in the industry, working with large health systems and payers, is we talked about this number here on the screen, which originally came from the Institute of Medicine, that 25 and other studies say up to 40% of what's currently spent in healthcare isn't needed. There's so much friction in healthcare, right? We have to, I think, as you illustrated with your wife, we have to make an appointment and maybe 6 weeks out. Who knows what happens in the meantime? We have to take time off work, get in a car, find a parking space, get into the office, fill out a clipboard they give us because somebody's going to do that and get system. And then they move us into another room where we wait for the doctor. Somebody comes in and gives us another clipboard, and then we leave and we forgot all these things that they told us or questions we wanted to ask, and half a day just went by. So, Amazon did this with bookstores, right? Made the service very different, and I think you just described it very well with your wife. So maybe we can get our arms around that waste that's described. So what do we mean when we talk about value-based care, Bradley?
So value-based care is fundamentally, it is the shift from moving from fee-for-service, where you essentially go in and you pay for the service that you receive, to moving to what we call fee-for-value, where you pay, and it's not an every time you go in you pay this amount. It's let's take care of the individual and figure out how much it should cost us to take care of them and have that as our overall cost, rather than this variable cost that we have every time. So I would say that's kind of the world of value-based care. And I love what we have here, the shift in the different payment models, where, fee for service, when it was first around, it made a lot of sense. Back in the 1950s, you're like, yeah, it makes sense. But just with how complicated things have gotten, how advanced, how specialized we are, there's a lot of angst, I think is a good word to say, about like, okay, what do I really need to pay for, and what's the right thing? And there's just a lot of muck to go through, if you will.
No, that's a great example. I often do this analogy of we're medieval. So, in the medieval ages, you went to the local shoemaker, you describe what you want, he'd make you a shoe, you'd walk out and he'd give you a bill for it. Now, obviously, you need lots of different types of clothing and other things, maybe transportation, those are all different vendors. And that's similar to what we see in healthcare. We have all of these different primary care, specialists, hospitals, CVS, Walgreens, pharmacy, maybe a home, and they're not connected, right? They don't work together, and yet the healthcare costs are spent in a fee-for-service, make me a shoe, give me the bill for it, but they're not working together around the whole person's health. So a way to think about this idea of shared risk and global capitation, and what's needed to actually get there?
So there's a couple things that are really needed to get there. So first is a change in mindset, right? I think that's the big hurdle that we have is, moving from a fee-for-service world where everything is based off of, there was a great cartoon several years ago where it just had, kind of a factory belt, and it had people going through, and it's like 7 billion served, and just kind of cranking people through, where you're like, okay, that's a fee-for-service mindset. And we have to shift that mindset to say, okay, how do we really take care of the overall health of this individual? And think about it more on those terms, rather than, so it's how do we keep people healthy versus how do we treat people when they're sick?
No, that makes a lot of sense. So when we talk about risk, maybe you could elaborate, particularly with the clients that you serve, the many different health systems, around like how they view this idea of taking risk and what it means to them, because that seems to be a risky business, if you will.
No, it definitely is. And it's a very different model for the provider organizations, because, payer organizations, they've been taking on risk for years. Like they know how to do this. They have the actuaries to help them understand what's going on. The provider organizations, a lot of them are saying, okay, let's go into this, but let's start really slow. So, and on this stair step here, where you have this shared savings, where it's a pay for performance, or it's an upside only contract where they say, okay, we're just going to learn about this. It's going to be a small percent of revenue, and we're just going to dip our toes in this and figure out how we can be successful. So as they take on risk, then there's kind of one of two things that happens. And there's more past than this, but kind of in general, one of two things happens. Number one, they say, oh, we think this is going to be awesome. And then they try and take on as much risk as humanly possible. And they see the vision. They say, okay, we're going to have we're going to go straight towards capitation, where we get a fixed payment of our per member per month or per member per year. And then we can take that and we can say, okay, here are our costs as a health system. Here's what we're going to earn as a health system, and balance that out. But that's hard to do. And then there are others that, they get their toes wet and they're like, okay, we don't know how we're going to be successful in this. This is kind of new world. And since this is such a small portion of revenue, maybe we'll just stick with fee for service until we see a more clear path forward, or until we're forced to change. So those are kind of two stories. And then there's a lot of ground in the middle there of people moving a little bit more one way or the other.
That makes a lot of sense. Kind of like an on-ramp to see if you can get on the highway.
Yes. Yeah,
So-
and if you're getting onto the Autobahn, you got to step on the gas and and go, otherwise you're going to miss your window.
Great. Let's check in to see if Dr. Shaw's there. Dr. Shaw, do you have anything to add to this, getting on the Autobahn? Okay, it sounds like we're still having audio connections with him. So let's review, at class, you've done a lot of work because you have that view of kind of where everybody is at with this. What's the current status of the idea of the hospitals or health systems actually taking on some form of
Sorry, Dr. Nace, I think I was having some audio. Could you repeat that question? Apologize.
I think we did lose Dr. Nace. Dr. Nace, I can see you again.
and I can hear you as well. I think you and I will be doing this. I think Dr. Shaw has some connection problems that boot me out. Oh, there he is. Wow.
Oh, look at that. It is great to see your smile, Dr. Shaw.
Thank you, sir. We figured this out, but sorry about the technical problems. But sorry, Dr. Nace, if you want to repeat that question, I'll love to answer it.
We can do that in just 1 second.
Also, Dr. Shaw, I like that shirt quite a lot.
Thanks for having
Yeah, well dressed for today. I'm glad we got you on video.
Thank you, sir. Not as well dressed as Dr. Nace. He always steals the show.
Okay, I've got to go back to being presenter. And to our audience, many apologies. I think we've resolved our technical difficulties, and Dr. Shaw is now with us not only in spirit, voice, but by video as well. Welcome, Dr. Shaw. So let's pick up the conversation where we were at. We were talking about this move to value-based care. Bradley had given a perspective around, kind of where things are at with that. I wanted to get your perspective as well. So.
Yeah, definitely, things are changing. I believe there was a slide on different value, fee for service to global capitation. We're on the same journey at Dignity Health. We manage 330,000 lives. 50,000 of those 330,000 lives we take global risk or full capitation on. And we're on that spectrum change where some of our contracts are shared savings, some are upside only, some with up and downside, the whole. So we're slowly moving towards that global cap model. And I think then I heard the analogy before, like we're on the on ramp to the highway, right? We're getting our feet well, we're getting our regulatory structures in place, we're getting the proper, Knox-Keene license, which is in California, you need that to be a global risk kind of carrier. So we're on the on ramp, we're figuring this out, and we were struggling. I mean, we struggled initially because we didn't have the proper data models and proper way to actually capture risk, quality, utilization, and all of that above. And that's why we partnered with Innovators was one of the reasons. But yeah, we're on that on-ramp model, and we're slowly going towards the full global cap model. Our goal is to get towards a global cap structure eventually.
And Dr. Shaw, just a question from me. How long did it take for you guys to say, hey, we see the vision? And then one of the things that we've seen is that the executive team, like the entire executive team at the hospital, has to say, yes, this is what we want to do. Like, was that a quick transition for you at Dignity Common Spirit, or was that more of a, this is going to take some time before everybody's bought in?
It wasn't, obviously we had some internal discussions around this topic, and we had some buy-ins from some of our leaders, and we really started on this journey around 2017, 2018, as part of this global risk model. So we acquired a couple of IPAs, we acquired we acquired the Noxine license from the state of California, and we're on this journey. So to your question, yes, we have some great hospital partners locally here in Central California that saw the vision and were on board. But this remains for us kind of, a test market or a trial market. We see the benefits, we see the whole person care model, we see it working, and we want to expand. But for right now, we really need to prove this model out and again, just get good at it. The payers have been doing this forever, and we need to learn the skills and build the skill set and learn to play the game well. But yes, so we're on the on-ramp.
That's a great perspective. We actually have a webinar coming up, just a little teaser for everybody, with Dr. David Nash at the Jefferson College of Population Health around the payvider. And that brings up the concept you just brought up, that payers have been doing this for a while, providers need to learn it, and maybe there's an opportunity for that to come together. But that being said, I want to point to a very important piece here. Bradley, you spoke about your wife's experience suddenly doing telehealth. And that really is a change from being service-driven, meaning all about the service, right, the doctor in their office, to being patient-sensitive. Walk us through a little bit about the other colors here on this journey.
Yeah, so there's a lot that goes into this, right? Because when you shift to the fee-for-service model, that it is a very provider-centric model, right? It's all about the clinician and their time, whereas now we need to shift over to the patient and their time. And I remember going to a conference, and I think this was like 4 or 5 years ago now, but I heard Dr. Glenn Steele from Geisinger, and he said, our vision is that the patient will come to the hospital and we will be there as a team, and we will say, we are so sorry that you had to come in today. Let's take care of you. And then they just go in and they do everything, and then they send them on their merry way. And like, that's the vision of where they want to get to. And I'm like, well, that's not my experience, I'll tell you that much. And so there's a lot of tools and processes that need to go into place. And I think a big one that's happening right now is just the whole data side of things, where I've heard it said that the microscope was the best invention of the 1900s because it allowed us to see what we couldn't see. And then the best invention that we have now is big data, because it also allows us to see what we cannot see. And so getting healthcare data elements together, let's just say it's not a walk in the park. Dr. Shah, you're smiling like that's been your experience here.
Yes, no, getting these disparate systems to talk to each other, different formats, different class, different frequency, different everything, right? I think we've all been there. So getting them to all like normalized, standardized in one kind of platform, so it's not just garbage in and garbage out, right? So so we can drive some sort of insights from it. Yes, it's challenging, and that's the key to all of this.
So I was speaking with Michael Dowling, the CEO at Northwell Health, and he said, given the pandemic experience, they've changed. They've done telehealth, they've done more patient-centered care, and he said, we're not going back to the old way of doing things. So what have been some of the barriers that we've seen to really moving forward with this more patient-centered, whole person care, risk-based care, value-based care? Bradley, let's start with you.
Yeah, so a couple of things. So I'll do two, and then I'll let Dr. Shah chime in. But one big thing that we see is a lot of friction between different entities. So this could be the payer and the provider system, right? Where they both have the same goal, but it's like, hey, we need to share data. And you're like, okay, well, give me all your data. No, you give me all your data, and then nobody shares data. And it's a hard thing. And the other is just it's a fundamental change in business model, like we've been talking about, and just saying, okay, here's how you've done business for the last, 30, 50, 70, 100 years, and we're going to change that. And no matter what industry you're in, changing the way that you do business, that's hard. And I think it's even harder in healthcare with all the different rules and regulations that we have here.
Dr. Shaw?
Yeah, pre-pandemic, we had some challenges getting some large group, we have a network, IP of independent network providers, so large groups who take capitation or subcapitation and have some risk or some skin in the game kind of thing. But during the pandemic, they saw that a lot of specialists, especially like say plastic surgery, dermatology, where these were elective and they were really relied on fee for service, that business really dried up and they're struggling financially because going to see a dermatologist wasn't a priority for most people, right? I mean, they kept things off. So they saw that, hey, the providers are on this risk-based arrangement where the capitation payment was basically guaranteed, right? They were going to get paid. And they saw the value of it for first time. They saw value of this kind of even payment system and not just fee for service. So from the independent perspective, actually some of those conversations were made easier for us because we were able to show that, look, we're with you in this whole journey together. When you provide good care and take care of your patients, we're there with you, and also we're there with you with financially. Your upside and our upsides, we're all aligned in the same way. So.
Mm-hmm. Yeah, and I've definitely seen that, Dr. Shah, across the country, because one of the things that happened in the pandemic was fee-for-service was exposed for the monster that it was, or is, I guess. But there were a lot of health systems that, they took a big hit because of elective surgeries and people being scared, frankly, to come into the hospital. Because they're like, I don't know, well, do I get COVID if I go there? And so there was a lot of fear. So it was a question mark of, okay, well, how many millions are we going to be in the red? Q2 financials last year. I remember having some of those conversations, and then looking across the fence, out their neighbors, whoa, they're fully capitated over there. Looks like business as usual for them. Okay, we got to get some of that. We need to do some of that over here. And so between 2019 and 2020, and this is a study we did with Chime, just so based on that last slide, 26% of overall revenue. Last year, that grew now to 29% of tied to value-based. And the biggest movements we saw were in bundled payments and capitated contracts. So I think we're just moving further down that spectrum the further we go along.
Well, that's a great segue to our audience. And then I have a couple questions from the audience. But first, let's check in with them and see where their organization is in the near term. So for those of you in the audience, we have about 250 of you. Please go into the chat box and please answer this question. Well, what is your organization's focus? What will it be in the near future? Strengthening virtual care and telehealth, like Bradley's wife experience, ensuring interoperability, and that seems to relate to the data challenges, the big data issues that both panelists discussed, enhancing your technology capabilities to leverage the data, patient and provider engagement along that continuum of more patient-centered care, or addressing the social, economic, and environmental issues that we're going to talk about in just a few minutes. So while we're waiting for that poll result, I have a couple questions from the audience. Bradley, how does this differ, this move to risk-based capitation from the HMO experience back in the late 90s?
That's an excellent question. And so there's a couple of key differences, because I will say that there are many that say this feels like HMO is just being shoved down my throat. And I'm like, okay, but a couple fundamental differences. between the 90s and now, we have actual data that we can get to. So that's the biggest difference, because in the 90s, everything was on paper. And so aggregating data and understanding trends and everything else that's going on, that's impossible. So being able to have that view, that's the biggest difference. And that's the thing that makes the biggest difference for the providers that I talk to.
Well, that's a great lead into another question from the audience, and I'll direct this to Dr. Shaw. Are there any software systems that are tracking the real-time episodic cost of care for patients in their, the question was, 90-day journey? I assume that means when they start a more acute episode in the next 3 months.
Yeah, so we have episode-based we track costs based on episode-based by DRGs and APDRGs, etc. So we do manage it, and then we use those kind of episode costs as one of the indicators on how we compare our different facilities and different provider groups, etc., especially the hospitals that are in our global cap models. We did not have this capability pre-Innovaccer. We actually, because the data was just so disparate, like and the interoperability and then different EMRs and such. So once we were able to kind of get that data layer streamlined, we were able to do those kind of comparisons and episode-based care modeling.
So it sounds like things are moving forward with the pandemic. Let's check in with the poll results and see what our audience said around their focus. Wow, it's all over the place. Bradley, what do you make of these results?
I like these results. So here's a couple of things that come to mind. The interoperability question, that and you can also say, the term interoperability means so many things, right? It's a really broad term. And what kind of interoperability are we talking about? But that's a huge part of the conversation these days is, hey, how do we make sure we get the right data to the right person at the right time? So, and I can say that goes hand in hand with technological capabilities as well. But there's a lot to do. And I think that data discussion really strengthens what people are looking at to do here.
Dr. Shaw?
Yeah, it aligns with also what we're trying to achieve in terms of technology capabilities, interoperability. We're investing very heavily in cloud computing and cloud resources. Trying to move. We have a lot of stuff on-prem right now. We're exploring, how much can we do, even a hybrid model, or how much we can move to some sort of cloud computing models, or how much, and also interoperability. I mean, the rules are also changing from CMS, and some requirements, regulatory wise, there are coming down. So yes, I would have answered those two exact interoperability and technology capabilities, because that is a very key area of focus for us.
That makes sense. Well, let's move on. We've talked a little bit about this idea of payers and providers collaborating. If you look at the 7 o'clock on a clock on this model, this comes from a McKinsey article in the middle of the pandemic. We've traditionally thought about technology connecting the consumer with traditional modalities of care, outpatient, hospital, et cetera, pharmacy. But then we have the payer up here at 11 o'clock, which supports the financing, but they don't traditionally pull their data and work together. And that seems like an opportunity. And then, that 34% of the results showed this social, economic, and environmental SDOH data as increasing recognition with the pandemic. What do you make of this idea of the ecosystem, and what do you think it means for us thinking as we go forward?
Yeah, so I completely agree with this ecosystem. It is, I think, where we're going towards, but I believe a lot of especially the large health systems, we're going to develop some of these capabilities in-house. And then the real question is, what do you invest in and develop in-house versus what do you kind of like outsource or partner or collaborate with, whether it's payer, provider groups, FQHCs, et cetera, right? I think not all of us can be jack of all trades, but I think we should, based on network access, availability, contracting, other resources, we will have to develop some of these capabilities in-house and seek help for the others that we just can't.
No, I think that's right. Providers have tried to move into standing up a health insurance arm. Health insurers have been buying practices to try to move in the provider arm. And then we also know that there's these joint ventures. So Bradley, I'm going to give you a tough question that came in from the audience. Payers have been doing this for a long time, taking risk, and that's what they do. But speaking as someone who has lived inside multiple payers, they don't always do it well. And then also from a provider perspective, they often deal with multiple payers. So the question then, how do you think we might do this differently?
So we've done an interesting study over the last couple months, and this will publish probably next month, so end of next month. But we went and talked with leading organizations who are taking on downside risk, where maybe half of their book of business or more is in downside risk. And one of the things that came up as a key learning for them is how they talk and negotiate with their payers. So two key things that come up with this. So number one is with their data. When they have their data and they understand their data and they can understand their patient population, they are armed to go and negotiate with their payer, right? So that's a huge part of the conversation. Oh, thank you for this. But being able to say, okay, here's the risk and here's how we want to attack it. And then the other thing that has come up as a key learning, especially working across multiple payers, is saying, okay, here are the things we want to focus on as a health system. Mrs. Payer, Mr. Payer, would you align with us on having these as our key metrics? And almost universally, the payer community has said, yes, we will align with you on those. And then you can say, here are the data elements that we need from you so that we can chase these and report on these to you. Is it okay if we're aligned on those, right? And just having those alignment conversations just makes things so much easier, because then you're not chasing, these three things from this contract, these 5 things from this contract, these 7 things from this contract, and there might be 1 or 2 things that overlap between them, but it's kind of just feels like you're chasing your tail all day long. So that data pillar and the analysis, so those first 2 pillars of population health here, those really help to arm you as you go and have those conversations with your payers. Now, and I will just say that these pillars came out of a construct that we developed back in 2016, when, if you remember HIMSS that year, every booth was population health, and you'd say, okay, what do you guys do? And they're like, we are a document imaging company, but we do population health. Like, okay, that's great. And so after that, we said, let's really define what this is and what does it take to do value-based care and do it well. And so these are the pillars of value-based care, where you have your data, you have to get it together, you analyze the data, there's care management, care coordination, there's the administrative financial reporting. You can read them all here, but those are kind of the core tenets. And then there are technology portions of this. There are potentially outsourced services that you can have, and potentially advisory services as well to help you understand what's going on. So all of those are outlined in a white paper that we have on class. So maybe we'll have to include that as a link so that those that are attending can get that after the webinar. But those first 2 pillars have become even more key in these conversations, because if your first 2 pillars are good, then you can make good decisions on all the others. If your first 2 pillars are bad, then you can make some great decisions based off of bad data and they won't turn out well.
Yep, and I think, Bradley, we've had lots of conversations with class and are thrilled with this concept of data acquisition and management, data analysis, sort of a data platform and analytic platform being key. And you can actually start to think about bringing in multiple payer data along with provider data from different sources to get there. So that's been great. Let's move into talking to Dr. Shaw about his experience with this, because they've done some global capitation. Walk us through, Dr. Shaw, a little bit about Dignity Health, and then some of what you've been doing in this regard.
Yeah, so Dignity Health MSO manages Dignity Health Medical Networks, which is on 3 different IPAs. So in Santa Cruz, Central California, which is south of Fresno, Tulare County, Kern County, which is Bakersfield, and also do Inland Empire, an IPA there. And we cover roughly about 330,000 lives. We take global risk on about 50,000 of those 330,000 lives. And then my largest line of business is Medi-Cal, so Medicaid. 3 hospitals in the global risk model. Obviously, I'm more in the shared risk models. 400 plus care sites, and then 2,400 plus providers in the IPA networks, PCP specialists, et cetera. We have been we've been like I mentioned before, when we first got in, we struggled. I mean, we had to figure this out. We inherently had to develop these skills set to manage global risk from and patients care from end to end, whether it's developing our care coordination capabilities, getting better utilization metrics, getting better at quality metrics reporting, HEDIS score reportings, et cetera. I have a saying with my providers that there's data gaps and there's quality clinical gaps, right? So really, as an IPA MSO, really we focus on closing the data gaps so we can have better insights in closing the clinical gaps. We've gone through this journey. We've gone through this journey in different steps. We aggregated first so speaking of closing the data gaps, we integrated a lot of different sources from data, so we integrated from the HIE in Santa Cruz to our different lab vendors here in the market, so going direct to the data sources to certain EMRs with the Dignity hospitals and the foundation system. And we really leverage these insights from these multiple data sources to improve our star ratings. We improved our largest MAPD plan. We improved from 1.7 star to 3.23 star rating as of 2020, and the final one in March of 2020 that came out in March of 21. So I mean, improving over 1+ star was very pretty significant for us. Also, we improved our ACC and RAF scores. We were traditionally about 0.7, 0.8 RAFs, which was below the market, the county, and averages, or even the health plans that were part of the network averages were substantially below. We're finally at the network averages or the county and the system averages, or in par with it. So we're accurately able to capture and stay up with these payers that have been doing this, like I said, for forever, right? So they really know so we're finally able to do those things. And then the last thing I want to talk about is the physician metrics. We really were, when we got these different data sources, and try to close this from this disparate systems, disparate data types. I mean, you name it. Like I said, 90% of my provider network's independent. I mean, you name an EMR, I probably have it in my network, including 15% of my network is still on paper, which is, if anybody out there is, yes, 15% of my doctors are on paper still. So it is very challenging in this environment, right? But even with all those challenges, we were able to integrate effectively and let the work speak for itself. In 2020 for IHA, the AMP, the Aligned Measure Perform the commercial, we won the Dr. Ronald Basinger Award for quality improved, the most improved quality for the Central California region. And then for the Inland Empire that I talked about, we won the AMP most improved Medicare Advantage plan for the network. So again, like Bradley, as you mentioned before, really creating that fundamental data layer and having access to those insights was the key to all of this.
So that answers a question that came in from the audience, is that are there any platforms that build a total view of the patient? It sounds like you're in the middle of building that to kind of get to the same pillars I think we heard from Bradley on the class side. The alignment here around your journey seems to fit those pillars very well. If we go back and think about the broader continuum, right, where we've got at 7 o'clock providers, at 11 o'clock payers, and then this social determinant of data, and then patient-generated data, more virtual care, getting data from the home and from maybe key stakeholders in the person's life, and then having wearables. Bradley, do you see the idea of data aggregation platforms bringing all this type of data together?
Eventually, yes. And one of the interesting things that has come out of the framework is, you and I have worked together closely on this, Dr. Nace, and with the Innovator team, just to understand what does it mean to be a data platform. We actually are working on a report just to give an early idea of who's out there and what kinds of capabilities do they have to be considered a data platform. Because there are a lot of people that want to be a data platform, but they are not, because they don't do everything that we need in the space. And now, one thing that I will say is there is always a desire to bring in more data sources. That's always a desire. If I were looking for a partner in this space, what I would be looking for most is not how many data sources they can bring, but how well they can make sense of the data sources they have. That's probably the number one thing that I would be thinking about.
Well, that makes a lot of sense. Let's check in with our audience again and see what problem they're currently faced with around this issue of bringing in data and using technology to move in that value continuum of creating risk. So is it improving the operational efficiency of what they currently do, getting the team to work together better, improving the transitional flow of the patient journey of moving from hospital to step down to SNF or post-acute to home, or chronic care management for those people at high risk? Is it optimizing their current technology infrastructure and reducing their IT costs? And a lot of IT costs. People spend $1 billion on one software across the country, or improving utilization with real-time analytics, more of a payer perspective as you move into risk. While we're waiting for the poll results, one of the questions is, where is disruption occurring most in the healthcare value chain currently? Some areas are harder to change or to make that change, and it will take longer. The person asking this question asks for your thoughts, please, as panelists. Let's start with you, Dr. Shaw.
So first, sorry, Doctor, can you just repeat the first part of the question?
Yes. Where is disruption currently occurring most in the healthcare value chain?
Yeah, I think the disruption is really occurring in getting insight. So when I say insight, is the buzzwords, and I think these will be the buzzwords that HIMSS this year is AI or machine learning, right? So to me, that really means insights. Like, great, we have these dashboards, great, we have this data, great, we have all this, but how does that actually affect someone's life? How does it affect someone's health and care? Fundamentally, all of us are in business because there's a sick person at the end of the day that we need to take care of. So what I really see disruption is like, how do we get to that proactively, and how do we deliver care proactively? How do we deliver care before the patient or the member reaches out saying, hey, I need this? So if we can get into that kind of preemptive mode, I really think that would be very disruptive to the whole delivery of the model, because now if we say, hey, patient X, needs this, but we anticipated that need and we already had those services lined up and create that seamless experience for the patient. I mean, that's a win-win for everybody.
Bradley?
Yeah, no, that's well said, Dr. Shaw. Being able to anticipate the future and the future needs of your population. I also see a lot of, like, if I were to just say, okay, where am I seeing a lot of disruption right now? The payment side. So whether that is, internally with the hospital system themselves, or as it interfaces with patients, that area, I think we're seeing a lot of disruption in that area. And then anything that touches patients. So I'll call it the patient engagement ecosystem. So all of those things, there's a lot of things happening in that area. And I think that, the AI and the machine learning can play into those as well, where we're seeing a lot of people that are trying to think about this differently so that we can shift to that consumer-centric model rather than the provider-centric model.
Great comments. Let's take a look at our audience poll results and see what they thought their current challenges are. Again, it seems to be everything. No surprise there. And I want to point out 2 questions that came out, I think have already been answered by both of you, which is, the role of post-acute providers seems to be big in driving down costs of care, that continuum, and then also bringing in the idea that this can be successful in rural environments, because Dr. Shaw, I believe you've done a lot of work with the IPAs you mentioned in Central California in the rural area. So 2 key questions I think have already been addressed. As we look to this broader ecosystem, let's talk a little bit about what the future looks like. Bradley.
So let me get out my crystal ball here. So as I look into the future, so we've talked about this move to a consumer-centric model. I think that's a wonderful future, and it makes healthcare better for all of us. So that, I would say we're still several years out from that. Couple things that are probably happening in the more near term is we're going to see more of a shift to value-based care, capitated contracts. I think we'll see a lot more of those. I think data is going to play a increasingly bigger role. So it's just going to, both the volume and the magnitude of the impact, that's going to increase. And my hope is that we have a healthcare system where it's easy to get healthcare regardless of who you are or what your status is in life. Those are things that I am hoping we see in the future.
That is a great vision for the future. Dr. Shaw, I think this idea of data being so important that Bradley mentioned, you've done a lot of work with us. Say a little bit about how data can help drive that performance in your risk-based contracts.
Yeah. So I mean, this goes without saying, right? Without having accurate insights or accurate, fundamental knowledge, data, essentially, you can't make high-level strategic decisions, high-level plan. It's like driving a car without knowing your speed, without a speedometer. You don't know how fast you're going. I mean, you can guesstimate, but it's a guesstimate, right? So so this framework, encompassing this disparate sources, claims data, pharmacy, EHR, all that stuff, you really need to put it together in a standardized, normalized, clean environment where so it makes sense not only to the physicians, the staff, the care managers, the executives, the administrators, but also the patient themselves, right? So when they want access to their insights or they want access to their own, like, hey, what can I do, or how can I control my diabetes better, or control, something, knowing the insights, knowing the trends, knowing how they did in the past, like we can push out, again, this is kind of the anticipatory need. We can push out, hey, you're always controlled, great, keep doing what you've been doing, just exercise more, or, et cetera, versus someone who's been like up and down. Maybe they need a little bit more. Maybe they need to go see a diabetic educator, right? So anticipating these needs, but all this is fundamentally enabled by a data activation plan, or a data platform and a data layer that drives this whole change across this ecosystem.
Yeah, thanks. And this is obviously our view here at Innovacer. And the question that just came in from the audience, which I think speak to moving to that vision, Bradley, you spoke about, is 10 platforms, the idea that class is supporting this idea of platforms, data platforms. Can that help to build a total view of the person, not just the patient, that can really facilitate that movement to true personalization of care? And I think that speaks to that chain from moving to provider-centered care to patient-centered care. What's your view of that with that crystal ball you just described?
So I think it can happen. One of the big hurdles that we face with that is, how do you get the data on the people that don't come and see you, right? So those that don't come to the hospital system. So let's say they're, young, healthy, good looking, like Dr. Nace, and they just say, you know what, I don't need to go in, and I don't feel like I need to go and get an annual physical because, I'm in good shape, and I never touch the health system. How do you understand the data for that individual, right? So that's data that most places aren't even thinking about right now. But when we get into this broader world to say, okay, let's look at social determinants of health. So, because we'll know where you live, because you probably have health insurance. And if we have this collaborative relationship with our provider, we'll be able to get some of that data. And, if your employer is incentivizing you to do some step challenges, we'll get some wearable data from you as well. So then maybe we can start putting together a picture of what does an individual who doesn't come to the health system look like, and how can we help them take better care of themselves? So can a data platform do that? Absolutely. Are they doing it right now? No. But it's a great vision to have for the future.
Yeah, and I'd like to point to some of the work that we've done at the Accountable Communities of Health, where we've been able to bring in the community-based organizations for housing, social work, transportation, criminal justice, all into one platform for closed-loop referrals so they can work together. The framework we like to describe here is the Care as One framework. And we're seeing that more and more here in California with the focus on whole person care, which really encompasses this view of the community, the social determinants, the behavior, understanding that, and really getting all the data together as a patient-centered view, and having all of these folks, the doctors, care managers, the pharmacists, the patients, their family members, all working together off the same information and the same insights. So, I really like the questions that came in from the audience. I think just want to ask if there's some closing comments just to wrap this up, because this has been a great discussion. Dr. Shaw, final thoughts?
No, the future is exciting. As a physician, I really think this is the changes that are happening. I think there's good intention and good thoughts behind it. Now it's all going to be about execution, right? And how we create this future ecosystem together, right? So this is very exciting as a provider and someone also who's in informatics and value-based care space. This is very exciting.
Bradley?
Yeah, I agree, Dr. Shaw. It's a very exciting future, and it's a very bright future. And it's great because we're seeing things change. And that change has been in the right direction. I think the pandemic has helped us refocus on what is very important. And so as we move and execute towards that, I like the future. And I think it's going to be even better than it is today.
That's such a bright look, I think, going forward after this year and a half we've been through. So the future does look very bright. We're excited. Want to thank both of you and our audience for participating. We will send out a copy of this slide deck. And Bradley, if you provide that link to our team, we'll send that out as well. Would love to have you learn more about us and us to learn about you as each of you surmount your challenges in moving to the future of healthcare. Thanks, everybody, and this concludes the webinar.
Thanks, everyone.
Thanks, everybody.
All right, everybody have a great day.